Alright, so as we wrap up infectious disease, there's still a very heavy burden in this chapter of making sure that you've gone through and revised all of microbiology, right? So we've been revisiting the microbiology chapter in the step one book a couple times so far. Whenever we've seen things that were relevant or anything that we didn't remember, CK doesn't necessarily test you too much on the various characteristics of bugs, whether or not something is gram-negative and whatnot. But they can, and that's the part that kind of sucks. So, in general, everything that was fair game for step one is still fair game in CK2. Like, you can still get questions that are completely about biochem metabolism, like the urea cycle or G6PD deficiency. These are not things that are now no longer a part of the test. And the only thing that really changes is how you get tested on it all, because now in CK you won't get direct questions about a single enzyme or something. You'll probably get a question where they mention an enzyme or a cycle, talk about an enzyme or a cycle, and then try to connect that to something else. And it's because they mentioned whatever they mentioned that you would have to understand something, and that'll help you figure out what the next best step is, whether you need to order test A or test B, or maybe give them a certain medication, simply because now you understand what it was that's not working, right? So that kind of becomes a bit of a nuisance when it comes to step two. Right now with the miscellaneous infections, there's these last few things that are infections which are related to other organ systems. Now, so far, everything we did do in an infectious disease was, in the CK book, divided by organ system or whatever system they're responsible for, right? Back in step one, it was more so just bugs being organized, all the microbes being organized based off of their own characteristics. So when you study both books together, you get to understand the organ system that they're related to, and then the characteristic they bring in terms of questions regarding that organ system. Now here in infectious endocarditis, we're going to see, as you can see, all those microbes right there. Those guys are all going to become pretty big deals, and of course most questions you'll get will have all of them as answer choices, and you would have to recall things. One of the more special ones here is when you get an infective endocarditis question and the culture is negative, right? Because then at that point you have the longest list. And most of these are bacteria that you probably never really mention. I mean, the Hasek ones, HSE-EK ones, those guys are extremely rare to see in any case scenario. Those are usually, they are tested though. Like we did earlier in this course, in the CK course, a question where the correct answer was, I believe, either Eikenella or Kingella. I can't remember. I think it was Eikenella. And you really never pick these answer choices unless it's pretty evident that they're looking for an HACEK group of organisms, and that's usually an infective endocarditis thing related to other organ systems as well. So we're going to see some of that as well. We're going to revisit infective endocarditis in step one also. So here they tell you infection of the endocardium, right? Because that's endocarditis, so it's endocardium that's messed up. Most commonly affects the heart valves, especially the mitral valve. Risk factors include other things that would mess up the mitral valve, so rheumatic heart disease, congenital issues like Marfan's, or valvular heart disease, which most commonly is regarding the mitral valve. It also affects prosthetic heart valves and IV drug users. So when it comes to IV drug use, that's going to be regarding mostly the tricuspid valve, because anything you inject into yourself will go into circulation and then come back to the right side. Right? So when it comes back to the right side, the first valve it encounters is the tricuspid valve. And immunosuppression. Etiologies are as follows. So the first breakdown is between acute versus subacute. Right? Those are two big things where what acute means. It's like it just happened all of a sudden, just recently. Subacute is it happened suddenly, but not that quickly. So acute is more suddenly than subacute. That's kind of what that means. Acute would occur in a day. Subacute would maybe occur in a week. S. aureus is the causative agent in more than 80% of cases of acute bacterial endocarditis in patients with a history of IV drug use. So S. aureus was the very first sketchy microbacteria, because it's the very first bacteria you learn about in first aid as well. And when you look at the picture for it, one of the key things besides all the other things that were important here was this this woman right here, right, with the 3 pyramids behind her for the tricuspid valve. That's why she has all these heart prints on her camel. And then back in the era where this picture is being drawn in, injecting drugs wasn't the thing. So they have a mortar and a pestle here to show you that you're making drugs, right? So she's coughing and stuff, and clenching her chest. That was something to remind you of one of the many things that Staph aureus really can mess up. So the tricuspid valve, that's the drug abusers, right? The other thing was the abscess and the diarrhea and the coughing and even the fishbowls for osteomyelitis. This guy with the super antigen effect of TSS, and so on and so on and so on. There's always so much happening, right? You want to be able to revise these images rapidly without really having to sit there and go through the entire story. But again, like I always show it to you guys, so you can always pause it and check it out when you rewatch the video later on, if you need the story. So Staph aureus would be the number one answer choice, and if you have even a few things in the question telling you or hinting at possibly Staph aureus, then you just pick it. Also, since it's basically always the answer, if you're completely confused, right? If you're ever doing an infective endocarditis question and you're really, really confused, what happened here? It wasn't wow. I'm clicking on the reverse button and it's not reversing. Interesting. Is this freezing up now? It is kind of freezing up. I'll let it catch up. But if you're doing a question and you're really not sure whether it is Staph aureus or not, then you can either go ahead and just pick Staph aureus, right? Because you don't know what the heck the answer choice is. You have to pick something, right? Don't leave it blank. Pick Staph aureus. Or if you're extremely confused, then it actually might be one of these things, right? Because when the culture comes back negative, it is pretty confusing. You just don't know what could be the answer anymore. And that can be pretty intimidating sometimes. Viridins should always ring a bell for dental procedures, right? That should be the immediate thought that comes to mind. Viridin streptococci is the most common pathogen for left-sided subacute bacterial endocarditis, so it maybe takes a week to come on. And following dental procedures in native valves, right? Native valves, so valves that are naturally supposed to be there, not prosthetic valves. They go on to tell you about the rest of this. So coagulase negative staphylococci, the most common infecting organism in prosthetic heart valves. So coagulase negative was your Staph epidermidis, right? Streptococcus bovis. Bovis was the one that was always related to colon cancer. So this has always been a question that gets tested with endocarditis as well. And it's always one of those new world questions that 90% of people get right, because as soon as they mention endocarditis and colon cancer or anything about bovis, these 3 topics go together. So you have to order a colonoscopy if S. bovis is diagnosed. Right, that would be the next best step. Candida and Aspergillus, these account for most cases of fungal endocarditis. Predisposing factors are usually just people who are doing things that would make them very vulnerable, right? So IV catheters, malignancy, AIDS, organ transplants, and even IV drug use. Here on the right side are the general summaries of the microbiology and clinical associations of infective endocarditis. Right, basically what we just looked at, and this is perfect. So this should be something you have in your mind, right? That you should just know this, and this is what you would be looking for in questions, so that you could pick the given answer, right? So like if you have gingival manipulation and respiratory tract incision or biopsy, you just pick Viridin streptococci, assuming the question is about endocarditis, and so on. So this is really good. This is also very important. The one down here, infective endocarditis in IV drug users, this is going to be basically, as we said, tricuspid valve with Staph aureus. Right? Often lacks audible heart murmur. Septic pulmonary emboli are common. Pulmonary emboli, right? So if you get a pulmonary embolism, so this is something that's very critical, because you, of course, get many questions with pulmonary embolism. But when pulmonary embolism questions occur, they're not septic. People don't get pulmonary embolisms with bacteria in it. Right? Most people get pulmonary embolisms because they have a very sedentary lifestyle, and it goes hand in hand with the whole concept of hypocoagulability and DVTs and all of that stuff, right? So those pulmonary embolisms are something happened somewhere in the body, and then something got released into your circulation. Usually some kind of atherosclerotic plaque got released into your circulation, or Um, some kind of platelet clump got released into circulation. The other case scenario we've seen is people with long bone fractures in the legs, right? Femur, tibia being broken. They do the surgery and whatnot, but then of course fat embolisms take place into circulation. So any of that goes into circulation, ends up in the lungs because that's what blood does. It comes back to the right heart, goes into the lung. None of those have bacteria, right? So when you get a septic pulmonary emboli, septic meaning that there's infection in it, there's bacteria in it, then you know that it had to be something that came from, of course, just the tricuspid valve. That's the only thing on the right side in your general circulation that could actually come all the way to the heart and then go into the lungs. Generally speaking, if you have any bacterial infection anywhere else, it won't really make it all the way to the heart and go into the lung. It'll just dissipate and cause infection wherever it's sitting. In this case scenario, it was sitting in the tricuspid valve, which is literally right there, so it enters the lung. Right, so septic pulmonary emboli are a huge topic. Many times questions will start off right by talking about the pulmonary embolism aspect. Right, they won't mention anything else. They'll try to confuse you into thinking it is just a general pulmonary embolism, but it's not. Right, the patient may have fever, which is one of the number one things you look for because labs and vitals, these things don't lie. Fewer peripheral infective endocarditis manifestations, which is a big deal because these people won't have the typical things we look for, like splinter hemorrhages and Janeway lesions or the oscillor nodes and whatnot. We're going to go back and take a look at that. Heart failure more common in the aortic valve involvement, but rare with tricuspid valve disease. This point will really just be there to help you understand how to pick one as a choice over the other. Because if they put, which valve is involved, then that becomes a little difficult. Now, of course, if you got a septic pulmonary embolism, that must be the tricuspid valve. But if you just have infective endocarditis and you're starting to present with heart failure, remember, most people's mitral valve is messed up, especially by a certain age. That doesn't lead to heart failure. So when you have a patient with some kind of major heart problem, infective endocarditis being the topic we're talking about right now, and then their heart is failing also, that's aortic valve. Remember that the huge topic about the aortic valve that we talked about that a lot of students often tend to forget is the fact that when your aortic valve opens, it covers behind the opening, so behind both of the opening of the valves, it covers the entrances into the left and right coronary arteries. And then as soon as the aortic valve closes, a little bit of blood comes back down the aorta and then gushes into the left and right coronary arteries, which is why we get that tiny dicrotic notch on the graph in step 1, and then that's also how we tell people that your own heart supplies itself blood during early diastole, right, when the aortic valve closes. So if your aortic valve isn't working that well, it probably won't close, right, because it's going to cause an opening into the other direction because of aortic regurgitation. If it's aortic stiffness, then it didn't even open in the first place, so not much blood came up, which means not much blood is going to come back down the aorta for that flow into the left and right coronary artery. All in all, if your aortic valve isn't working well, you can't supply your own heart any blood. That's why aortic valve problems will be the patient who's having heart failure symptoms. Mitral valve problems are not going to be people who are having heart failure symptoms until the mitral valve becomes extremely messed up with usually mitral stenosis that was so bad that now the left atrium is starting to get wide and expanded, right? Because the left atrium has to become more brolic so it can open that mitral valve. These are some good revision topics of things that you want to be able to talk about. Like I didn't prepare talking about this whole cardiovascular stuff before I sat down. I mostly just revised this. But being able to talk about that cardiovascular dynamics of how different valves get messed up, why the heart sounds change based off of various maneuvers, why certain heart sounds are heard in the places they're heard, these are big associations you really want to have down to the T perfectly before you sit for step 2, preferably even before you sit for step 1 if you haven't taken it yet, because you will get questions where they'll mention, of course, heart sounds and whatnot, and it's still not going to be extremely clear which valve is actually the problem here, right? So that's something you want to make sure you spend some time revising, possibly even today as a shock study method, to make sure you have it down. So now they go into things that are going to be more significant to us in CK, right? History, diagnosis, and what you're actually going to do to treat it. So of course, when these people come in with their endocarditis, they don't often tend to come in the very first day. So they've probably already gone through this period of having constitutional symptoms of fever, weight loss, fatigue, Exam reveals a heart murmur, but remember we just said that not always, right? You're not always going to hear a heart murmur, so that's very important to remember. The mitral valve is more commonly affected than the aortic in non-IV drug users. More right-sided involvement is found in the IV drug users, as we've discussed. Osler nodes, Janeway lesions, splinter hemorrhages, and all the other things, rot spots, these are all things you can see depending on how bad the endocarditis is getting. So how do you diagnose this? Well, diagnosis is guided by risk factors, clinical symptoms, and the Duke criteria, which we're going to see soon. So as you've already been seeing as we've been going through CK, there are all kinds of criteria and scoring methods, like the Wells criteria that became a big deal in pulmonary embolisms and whatnot, and DVTs that you're going to have to kind of employ on test day. So if we look at the Duke criteria, it's basically this right here. There's a major and minor for diagnosing endocarditis. So the major is when you have positive blood cultures for a typical organism, right, with either 2 samples drawn more than 12 hours apart or 3 out of 4 drawn over the course of at least 1 hour. Right, so you're getting positive blood cultures. That's all that really matters. Don't worry too much about the time span. You're actually getting positive blood cultures, and there's evidence of endocardial involvement because you did a transesophageal echo and you found a new murmur. Right, so that is a major criteria. The minor criteria are basic things that are non-specific. Minor criteria are things that you would see even possibly with other issues, like predisposing risk factors, fever, vascular phenomena, all the different lesions and nostrils and stuff, immunologic phenomena, microbiologic evidence that doesn't meet the major criteria. So basically you would have negative cultures here. Negative cultures like the Hasek organisms, okay, and echo findings that are consistent with infective endocarditis but do not meet the major criteria. So these criteria things, of all the different criteria, this here breaks it down even more, the modified Duke criteria. These are basically here to tell you that whether or not this person has infective endocarditis, but it's not exactly the most amazing thing. Like it's not, I don't know how to explain it, like it's not perfect. I don't truly see the purpose of the Duke criteria because you obviously have endocarditis if I found positive blood cultures and your endocardium is clearly involved. Like it's not, this table isn't doing something out of the ordinary. It's basically spelling out common sense or obvious logic. So it's I think the best thing this table accomplishes is breaking down major versus minor, which are things that are specific and more important for infective endocarditis, which is versus things that are not so specific to infective endocarditis. That's all this really does for you, right? So even here, like everything you're seeing in this and the clinical findings frequency, everything you're seeing in this table, it's not really that amazing. It's not like a Pulitzer Award-winning discovery or organization in a criteria. So it's just something you have to know. That's all, the Duke criteria, but not necessarily something you'll actually be employing in a question. CBC will of course always show leukocytosis in anyone with any kind of infection. A left shift, as we talked about when we did hematology, because you have infection, you're making new neutrophils, elevated products of inflammation. Right? These are all obvious things that you're of course going to see in anyone with any kind of itis, any inflammatory infection. So how do you treat this person? Well, you don't wait for cultures and stuff. You start with early empiric IV antibiotic treatment for the acutely ill patients. Vancomycin plus gentamicin is an appropriate choice for most patients. So you just start that right away. So that's a question that you're going to get. You don't wait for the culture. You don't wait for anything else. You just right away start empiric antibiotics, right? Because you don't want to wait for things to get worse. Tailor antibiotics once you do get the results, right? So once the results come back in, tailor antibiotics once the causative agent is known. Acute valve replacement is sometimes necessary if the rupture occurs. The prognosis for prosthetic valve endocarditis is very poor. If you already have a prosthetic valve and that has endocarditis on it now, replacing that won't really be the best thing, and it's probably not going to go too well. So it's a very complicated topic at that point. Pre-procedure prophylaxis. Now, these are things we do in everyday practice to prevent endocarditis because we know that certain procedures will lead to endocarditis. So endocarditis prophylaxis is only indicated in patients with the following: significant cardiac defects, right? Undergoing high-risk procedures like dental work, respiratory tract surgery, GI or GU surgeries, right? Any of these things are all different case scenarios where you would go ahead and start prophylactic antibiotics to save the patient from even ever developing endocarditis. So when most people have, I think the one case scenario maybe all of us have already shared is getting your wisdom teeth removed. So when you go in to get your wisdom teeth removed, you start taking antibiotics a week ahead of time, because that is under the category of a major dental procedure where you will be bleeding, you will be bleeding from your gums, and you will be swallowing a lot of that blood you're bleeding from the gums, and that exposes you to a lot of infective endocarditis culprits, right? So at that point, if you haven't started the prophylactic antibiotics, then things are going to be really bad. Amoxicillin is the preferred antibiotic prophylaxis. So this is something that people mess up often, right? If you haven't gotten infective endocarditis yet, you just give the person prophylactic amoxicillin. For patients who are penicillin allergic, you can use any of these other things, right? So penicillin allergies are pretty common. So what people mess up is that amoxicillin is before you get infective endocarditis, and then after you have infective endocarditis, you give the patient vancomycin and gentamicin. So don't confuse the two. You can't give vancomycin and gentamicin as a prophylactic thing. That's not how that works. So very important to make sure you remember that. Complications of focal neurologic deficits from embolic strokes, metastatic infection, heart failure caused by valvular insufficiency, and of course glomerulonephritis, which pretty much always occurs. So now we go back and look at infective endocarditis real quick. Bacterial endocarditis, right? That's what they call it here. So you have your From James mnemonic to remind you of the various findings you would have, right? Some of these which go into your Duke criteria. Notice how here in step 1 the Duke criteria is not mentioned at all. Not because you didn't really need to know it, but also because it's just useless. It's not something you can really employ, as I said before. One of the things to keep in mind is that ocellular nose versus Janeway lesions, I always used to forget which one is actually tender. So I went ahead and made this up, right? So ocellular nose are ouchy, tender fingers and toes, right? When you get a patient coming in with any new onset valvular issue and they have painful fingers and toes, it's a giveaway for endocarditis. You don't need to be given anything else now, right? Because why would you ever have painful fingers and toes? That doesn't happen. Nothing causes that, right? So it's just endocarditis that would be the problem in a person who is presenting with painful fingers and toes. And that's something that's very, very important to keep in mind, because that is usually the number one thing used in questions to help understand. If they give you the nail bed hemorrhages, that's too easy. That's a giveaway. Obviously these are happening because you have tiny emboli that are getting struck in the microvessels at the end of your fingers, causing this kind of internal hemorrhage, right? So that's rarely given. This is what's going to be given. Painful lesions in the fingers and pads of the feet and toes, and right away you go ahead and think, oh, this is endocarditis and it's getting bad. Now, how do you differentiate acute versus subacute? So this table here from a random book kind of helps. Acute bacterial endocarditis and subacute bacterial endocarditis, number one major difference, besides of course the time span, is the type of valve it affects, because then that tells you which bacteria is involved too. So with acute bacterial endocarditis, it'll affect previously normal, or what they called earlier native valves, valves that are yours. Organism is someone with high virulence, like Staph aureus or some kind of streptococci. Oftentimes nowadays, Staph aureus is no longer even an answer choice, and they'll give you a bunch of other answer choices, of which you would just pick streptococcus. You might not know which streptococcus, and it doesn't matter, you just pick streptococcus as an answer choice. If Staph aureus isn't there and the answer is about an acute bacterial endocarditis, just pick streptococcus. You don't need to know which one or where or whatever. That's not what matters, you just need to get the question right. Often involves a tricuspid valve in IV drug users. Vegetations may form, and that vegetation can break off and go into causing a septic emboli or destroy the valve, causing insufficiency. And these people usually have high fevers, over 102, with chills, right? So that's really bad. It happens now. Here in this table, they didn't break down the time span. So acute usually occurs very quickly, rapid onset, as you can see, right? Rapid onset. So within a day or two, and things get really bad all of a sudden. Then you have subacute. Subacute has slower onset, right? So they tell you gradual onset, right? It gets worse throughout the week, where by the end of the week, it's top tier, terrible, you're in really bad condition now. Organisms have low virulence, which means that they don't usually tend to cause infection in anyone. This is strep viridans, staph epidermidis, and most gram-negative bacilli. So if strep viridans and staph epidermidis are not specific answer choices that you can pick, you pick the answer choice that says gram-negative bacilli, and you're done. This encompasses almost everything that was in this list right here, actually. That description encompasses most of these guys. Right, so very important to make sure you remember these answer choices that are going to feel weird, but they're the correct answer choice. Right, streptococcus or gram-negative bacilli, because by the time we've come to now in 2021, everyone knows about Staph aureus and Staph epidermidis for the fake valves and whatnot. It's just become too common talk to get tested now, right? That's why tests are becoming harder nowadays, because a few years ago in 2010 and even in the year 2000, step 1 was significantly easier because there was no concept of high yield and what's commonly talked about, and we didn't have all these media things where people were learning these things so rapidly. So tests are becoming much harder. But the main thing here with the SBE, subacute bacterial enteritis, it affects previously abnormal valves. Right, so strep viridans we saw is going to be someone who didn't get prophylaxis and did a dental procedure out of nowhere, and now boom, strep viridans is going to cause platelets to aggregate on their previously abnormal valves. Right, it's either, so this doesn't have to be a fake valve; it could be a previously damaged valve. Okay, that is your own valve. Staph epidermidis is the one that attaches to fake valves. Right. More insidious onset with positive blood cultures, fatigue, low-grade fever with no chills, and you would see all these splinter hemorrhages and all the other things in both of them, basically. Right. Now, they don't mention splinter hemorrhages for acute bacterial enteritis because it happens so quickly that before you even see any of these things, right, you already see the really bad fever and chills. Whereas in the subacute one, since it's so slow, you actually develop this and the fever around the same time. All right. Other than that, there was one other really big topic. So you could have someone with infective endocarditis that's actually non-bacterial. So they call that merantic or thrombotic, right? Merantic is the no infection, and thrombotic is with platelets. You could have non-bacterial endocarditis, which is secondary to some kind of cancer, a hypercoagulable state, or lupus. Right? All three of which are very high-yield topics. Non-bacterial endocarditis is merantic, thrombotic, and can be due to many things. Malignancy, hypercoagulability, and lupus can all cause clots. Tumors such as mucinous cystadenocarcinoma make tons of mucus, and the fibrinogen and platelets stick to it and make clots. All of these clots get stuck on the inferior side of the heart valve. Very important to remember. Right, on the inferior side, not the upper side. So there's a weird dynamic to that, and there's a lot of physiology and physics to it, but basically, valves open in a certain direction. So you would assume that if something is coming from above it, it would stick to the top of the valve, not the under part, right? And then when the valve closes, apparently they come back and get stuck on the under part. When that happens, that's because there's clots that are not really going with the flow, right? They're going backwards. When the door is closing, it got sucked in backwards, and boom, it got stuck on the underside. This aspect is a very important thing to remember, because you'll get questions where patients die, they'll give you an image like this, or they'll tell you a description of the autopsy where they're going to say that there were a bunch of clots on the inferior side of the heart valve, right? That is usually not a bacterial one. The bacterial ones get stuck on the top. When the valve is closed, blood comes on top, and then eventually it's going to open, right? In that little bit of time when the valve is closed, imagine there's the mitral valve and blood came on top into the left atrium. Right now, in the time that the blood is sitting above, it's already starting to affect the mitral valve, and it's going to get stuck on the top side. Once it opens, it's just going to go into the left ventricle and then into the body and cause fever. So inferior side stuff is the one that's usually not the bacteria. Right? If vegetations are on both sides of the heart valves, then you just know and just safely pick lupus. Right? Lupus is an autoimmune disease. Anticardiolipin is in all animal hearts. The antibodies stick to both sides of the heart valves, leading to Libman sacs endocarditis, which they nicely help you remember, but I don't see it here. I think it's mentioned under lupus, but there's a mnemonic for this, which is that you get Libman sacs endocarditis in systemic lupus erythematosus, right? So LSE and SLE. That's kind of something that's written in the lupus part of the book, where they talk about this. And very important to keep that in mind as well. So these biopsy findings, or not biopsy findings, autopsy findings can be mentioned pretty commonly, and you need to make sure what to take away with it. Mitral valve prolapse is the most common underlying valvular disease predisposing people to the development of subacute infective endocarditis in developed countries, particularly when mitral regurgitation coexists. Right, so mitral valve prolapse is great for these bacteria because you literally create a tiny bag with the prolapsing valve for the bacteria to sit in. So it works out in their favor at that point, right? And that's basically all there is to really understanding endocarditis, but there's very intense questions on it most times. So let's start looking at some of the questions we have right here. We looked at that already. Okay, so first one here, 40-year-old man comes to the emergency department with 2 weeks of fever, malaise, weakness, and an unintentional 5-pound weight loss. Now, 5-pound weight loss isn't insane, so you don't immediately think cancer, but he's just not doing well. During the last 4 days, he got left-sided chest and upper abdominal pain. He has asymptomatic mitral valve prolapse. So he does have the mitral valve prolapse already, right? So 2 weeks of fever, his time span is telling you subacute, and the prolapse definitely predisposes him to all kinds of things, one being infective endocarditis. His wife was treated for an upper respiratory infection 3 weeks ago. He works for a large corporation and frequently travels to Mexico. So this upper respiratory infection his wife had is something he could get from his wife too, right? He works for a large corporation and frequently travels to Mexico. Doesn't really mean too much. He has a 20-year smoking history, doesn't use alcohol. Today his temperature is very high. I don't know what, this must have been some number like 15 or something, not 1. Lung exam shows decreased breath sounds in the left lower lung field with dullness to percussion. So dullness to percussion, remember percussing the strings of a guitar, they're supposed to make noise, right? But if you have dullness, that means that you're playing the guitar underwater. So that means that this person has some kind of pleural effusion in the left lower lung field. Cardiac exam shows 2 out of 6 systolic murmur at the apex. Imaging studies reveal left-sided pleural effusion. So they went ahead and even spelled that out for you. And splenomegaly with a splenic fluid collection. What is the most likely underlying diagnosis in this patient? So I don't know why people chose tuberculosis. 25% of people chose tuberculosis. I'm not sure what in this question made them possibly think tuberculosis. Right. It was just infective endocarditis. His presentation is consistent with the likely splenic abscess, which classically causes a triad of fever, leukocytosis, and left upper quadrant abdominal pain. Risk factors for splenic abscess include infective endocarditis or infections with hematogenous spread, immunosuppression, IV drug use, trauma, even hemoglobinopathies, as we saw when we did HEMONC. CT would confirm the diagnosis. You would see how big it is and what's happening. In infective endocarditis, septic emboli can hematogenesis seed to the spleen. Antibiotics alone have a 50% mortality in treating this, so splenectomy is recommended. His mitral valve prolapse gives a 5-fold increased suspicion of infective endocarditis. TB has nothing to do with any of this shit. Right, so that's kind of something. So this question I put here because it was very important to keep this in mind, that it can seed to the spleen. At which point the correct answer is to do the CT to check and do the splenectomy to fix them. Right? Splenectomy is recommended because just antibiotics alone doesn't work that successfully. Right? So this question itself is also teaching a lot of things here. So it's a great question to have here because they didn't mention this here. They didn't mention anything about the spleen being targeted in infective endocarditis. We didn't see it here either. Nowhere did they mention that it can, seed to the spleen and you need to do a splenectomy. So clearly it's like a nice topic that's not being taught. And that's why it's very important that when you do URO questions where you learn something really interesting that you've never heard before, you annotate that, right? And this is why I put it here. So very good question. But even if you've never heard of that, it was still more likely to pick infective endocarditis as an answer choice than tuberculosis. I didn't understand why 25% chose tuberculosis there. Here, same kind of thing happened with a lot of people picking the wrong answer choice, right? With something that you need to be proficient at by the time you get to step 2, because you needed to be proficient at it even in step 1, the pharmacology of antibiotics. 34-year-old man with no significant past medical history comes to the physician with a week of intermittent fevers and increasing fatigue. He was punched in the face during a street fight 3 weeks ago. Exam shows a 2 out of 6 whole systolic murmur heard at the apex. Lungs are clear of auscultation. Rest of the exam is unremarkable. He received empiric IV vancomycin. 3 days later, 3 of 4 blood cultures obtained grow strep mutans, highly sensitive to penicillin. What's the next step in management? So now, this was clearly, a bait that people grabbed. So the correct answer was switch to IV ceftriaxone, which only 30% picked. All right, and there was a good reason to pick this, but most people just fell for the bait. So I'm sure a lot of us would also fall for the same exact bait, because they did this, 3 days later. So you need to understand a couple things in this question, but let's finish it first and I'll come back to it. So 3 days later, they did this culture and they found that it is sensitive to penicillin. So 20% of people chose switch to amoxicillin clavulanic acid, and 40% of people chose switch to oral penicillin. So basically 60% of the total people fell for this trap and picked give some form of penicillin. That wasn't what was supposed to happen here. His clinical presentation is suggestive of infective endocarditis. It's pretty obvious how, because he was punched in the face, and getting punched in the face really badly is very identical to getting an oral procedure done, like a dental procedure done. So I'm sure this punch to his face must have possibly displaced at least one tooth where he started bleeding, right? And then after that, of course, because he has a heart murmur now. So they mentioned some kind of oral thing, and then heart murmur, definitely infective endocarditis. He was started appropriately on empiric vancomycin to cover staphylococci, streptococci, and enterococci after obtaining blood cultures. So that's the order of things, right? They took blood cultures, then they started empiric IV vancomycin, because you never want to do it the other way around. If you kill the bacteria, then try taking cultures, it's not going to work. So they took blood cultures, then started IV vancomycin, and then they go on and tell you most viridans group streptococci, like the mutans that he has, are highly susceptible to penicillin with a minimum inhibitory concentration of less than 0.12. Patients with penicillin susceptible strains should be treated with IV aqueous penicillin or IV ceftriaxone for 4 weeks. Ceftriaxone is easier to administer at home. Oral antibiotics are generally not recommended as initial therapy in patients with infective endocarditis. Parenteral antibiotics are better, because if you can inject the antibiotics into the bloodstream, all the blood is eventually going to come back to the heart and it'll kill the bacteria. Oral antibiotics can be considered once drug susceptibilities are known, but most are given in combination therapy rather than monotherapy. Right? So what was really the trick in this question was understanding, first of all, what's actually easier to do and what is really done, in everyday practice. You can see the little difference of penicillin V versus penicillin G. If another correct answer here would have been to switch to IV penicillin G. That would have been the other correct answer, but of course they didn't put that because that would be like too easy, right? It wouldn't be a trap anymore. So switching to, so the trick was paying a little attention on the oral part, not the medication part. Right? Both of these answer choices are wrong because they mentioned giving oral therapy. Right? That's not what you're going to do here, because this person has endocarditis. It's a blood problem in the heart. If you take the antibiotic orally, it's going to go into the stomach, go through first-pass metabolism, and then it's going to take a long time before even any of it makes it all the way to the bloodstream and the heart. That's another great question, making sure to point out some key little discrepancies that you can get bullshit questions on. Here in the treatment, they mentioned the IV antibiotics. They, not really much to do in terms of orally, but they didn't break it down the way that question did. And that question did a lot better job breaking it down, so very important to keep in mind. Now, the pre-procedure prophylaxis is oral. And as any of us who have gotten our teeth taken out, we would know, right? You go home with a bunch of amoxicillin tablets and you take it every day, and then you come in for your dental procedure, right? But the people who are getting treated after they have infective endocarditis, that's IV stuff. Everything has to be IV because you need it to get to the bloodstream and the heart. Here's a question where they talk about adult still disease, something you may never have actually heard of, but a lot of people picked it as an answer choice. A 42-year-old man comes to the office with 4 weeks of fatigue and weakness. During this period, he has had fleeting joint pains, low-grade fever, dark cloudy urine, pain in the fingertips, which is actually the giveaway, right? I told you guys that when you're reading these questions, most things you'll read about may be non-specific bullshit that doesn't really tell you anything. But when you read pain in the fingertips, that's endocarditis, because you don't ever really see pain in the fingertips. It doesn't happen. Nothing causes pain in fingertips besides endocarditis. There might be other things that do cause pain in fingertips, but as far as we're concerned with step, nothing but endocarditis causes pain. That's your ouchie oscillor nodes, right? In the fingertips and the toes and the pads of the foot. You even get it sometimes in like the lower parts of the fingertips, so that can actually be confusing sometimes with Janeway lesions, but be very careful. As long as they mention pain in fingertips, is infective endocarditis. Like right away you were done with the question, you could have just picked it. If you were running out and you only have 10 seconds left and this is the last question of the block, you just pick infective endocarditis and move on. You don't need to read the rest of the question anymore. You would get it right and not fall for what the 30% chose here. But let's read it anyway. So a bunch of findings that look like some renal involvement, some infection involvement, fingertip pain, and shortness of breath when walking fast or climbing stairs. So that's a heart involvement, right? Shortness of breath with exertion. Exams show swelling and tenderness in several finger pads, which is the oscillor nodes. They're really, really helping you out by mentioning the oscillor nodes twice already, right? CBC gives hemoglobin is a little low, microcytic, platelets are 215, which is normal. Leukocytes are high because he does have infection. Erythrocyte sedimentation rate is high because he has inflammation. Rheumatoid factor is 22, but again, rheumatoid factor is also very non-specific. It doesn't mean he has rheumatoid arthritis. Rheumatoid factor is very non-specific. It could mean he has rheumatoid arthritis, but all his other symptoms in this question are not due to rheumatoid arthritis, right? Urinalysis is 2 plus for blood and 1 plus for protein, which indicates that he's got renal injury. What is the most likely diagnosis? Infective endocarditis. That's it, not adult still disease. Infective endocarditis involves the endocardial surface and is primarily caused by bacteria. You develop all kinds of stuff. Labs often show normocytic anemia and elevated ESR. Right? This is between 80 to 100 is normocytic, but in the real practice, when this number is creeping towards 87 and creeping towards 80, you start assuming it's going to become microcytic anemia. Right? So that's something to keep in mind as well. And we talked about that when we did HEMOC as well. When the number is creeping towards a certain direction, you start thinking of diseases in that direction, like iron deficiency or some kind of heme or globin problem. And elevated ESR. To confirm the diagnosis using the modified Duke criteria, blood cultures should be obtained, followed by echo, if blood cultures are positive, right? Those two things will be the major criteria. Adult still disease is an uncommon inflammatory disorder characterized by recurrent high fevers, arthritis arthralgias, and a salmon-colored macular rash. ESR may be very high, but active urine sediment, painful fingertips, and pulmonary symptoms would be atypical. So adult still disease is just an inflammatory disease with some arthralgias and a rash. It's very easy to pick as an answer choice, but oftentimes it can also be very confusing to pick because this presentation of fever, arthritis, and a rash also mimics lupus. Or the other way around. Remember, lupus was the great imitator, right? So lupus mimics many diseases. And I can see why people would possibly think adult still disease, but I can't respect that because this question spent 50% of its time really spelling out infective endocarditis, especially with the pain in the fingertips. Very obvious, right? Down here, another question. Now, this time, again, it's like a 50-50 breakdown where I'm really not... I hope it's not the same question. No, it's not. I'm really not understanding why people are falling and picking tuberculosis, right? We just did that question right here, this one, where people chose tuberculosis, and I didn't see it. I don't see how you could think TB was the thing in this patient. Same thing in this patient, too. Now, this one's a female. So, 32-year-old woman comes to the hospital complaining of fever, chills, pleuritic chest pain, and shortness of breath for the last 3 days. She was found to be HIV positive 1 year ago. Her CD4 count was 378 about a month ago, so it's above the 200, above the 300, but under the 500. She does not regularly attend clinic appointments and takes no medication, so she's not using her heart therapy. She uses IV drugs Right? See, IV, heroin, and cocaine. Her only sexual partner is also HIV positive. Temperature 102.7, so she's got some kind of infection for sure today. Examination shows scattered crackles in both lung fields. Her abdomen is soft and non-tender without hepatosplenomegaly. Extremities exhibit several needle marks. Labs show leukocytosis because she has an infection. Hemoglobin is low. Platelets are normal. Imaging of the chest reveals multiple nodular lesions with small cavities as shown below with these x-rays right here. So, these CTs right here. So we're going to look at that. So that's the imaging they did. What organism most likely caused her current condition? So, as we've done this before, if you identify that it is most likely infected endocarditis, then it's an IV drug user, then Staph aureus is the easy answer choice to pick, and you move on, right? Why M. tuberculosis? That's Mycoplasma tuberculosis. Like I can see how maybe HIV would increase the risk and whatnot, but did the question really spell out TB things? I don't think so. Her presentation of pulmonary symptoms, history of IV drug use with track marks, and cavitary lesions on imaging suggests septic embolism from infective endocarditis. That's exactly how this presents. Okay, so we talked about septic embolism, right? Something that's on the tricuspid valve that then broke off and went into the lungs, causing an embolic presentation of pleuritic chest pain, shortness of breath. Not because of anything else, not tuberculosis, shortness of breath and pleuritic chest pain due to the embolism that's messing up the lung. HIV greatly increases the risk of IV drug users, most commonly at the tricuspid valve. Peripheral manifestations are less common in patients with tricuspid valve disease, so you don't see the Janeway lesions, ulcer nodes, splinter hemorrhages, stuff like that. Infective endocarditis diagnosis in IV drug users can be hard and requires a high degree of suspicion. Septic pulmonary emboli occur in about 75% of patients with tricuspid endocarditis, most commonly due to S. aureus and IV drug use with infective endocarditis. The vertical CT scan depicts pulmonary septic emboli as pulmonary infiltrates, abscesses, infarction, pulmonary gangrene, or even cavities. Lesions are typically in the lung periphery, like that. And they're showing you multiples here, right? At different levels of the same patient. As you're moving up or down the lung, right? You're seeing it at different levels. So you can tell it's different levels because the shape and design of the spine, which doesn't change too much going from here to here, where you encompass your entire lung, but it does change a little bit. And you can also tell it's different levels because you see the heart in different ways, right? So of course, one thing that changes when you move the CT from up here down here is you encompass the entire heart in the middle, right? So you don't see much of the heart here, not much of it there. Then you start seeing it, then you see the whole heart. And basically this patient has peripheral emboli that are causing the infection. See, you would get this question correct because, as I said, they gave you the imaging. Right? The question gave the imaging. Imaging of the chest reveals. Imaging doesn't lie either. And when you look at this imaging and you see these peripheral things that the black arrows are pointing at, that's not TB. TB would infect the entire certain section of the lung. Mycoplasma TB really messes up the lung. Remember with Mycoplasma tuberculosis, that was the M for IgM, the cold agglutinins, right? And that was also the one that was called walking pneumonia because the patient will be walking around looking just okay for the most part, and then you do their chest x-ray, not really CT, but you could do anything, and you would see a crazy bad looking lung, and you're surprised that the patient isn't hospitalized, that he's actually walking around or she's walking around just fine. That's not what we're seeing here. The lung isn't completely messed up here, right? So it's not Mycoplasma pneumonia. And that was just really something Mycoplasma tuberculosis, and that's something that people are clearly falling for, so be very careful with that. Right? And then now the last things here are anthrax and osteomyelitis, and we'll be done. So let's take a look at that. Anthrax is a big scare that had occurred a couple years ago here in America, right, where it was being used as a weapon of terrorism. Caused by spore-forming gram-positive bacterium Bacillus anthracis, infection is an occupational hazard for veterinarians, farmers, and individuals who handle animal wool, hair, hides, or bone meal products. Also a biological weapon. Bacillus anthracis can cause cutaneous, inhalation, or GI anthrax. Now, this is taught in step 1, sketching micro, really well. There's also a bunch of factors that are involved and the pathophysiology of it all done pretty well in step 1. There is no person-to-person spread of anthrax, which is a very key thing to keep in mind, because if you do start seeing person-to-person spread in your question, then it's not anthrax. Cutaneous presents 1 to 7 days after skin exposure and penetration of spores. The lesions begin as a pruritic papule that enlarges to form an ulcer surrounded by a satellite bulbous lesion with an edematous halo and a round, regular raised edge. Regional lymphadenopathy is also characteristic. The lesion involves a black eschar within 7 to 10 days. So it'll look like that. That's cutaneous anthrax, right? So you get this like ulceration, and then it all becomes black here, all right? Inhalation, this is literally going to cause pulmonary hemorrhage. Pulmonary hemorrhage, really bad. So that's why they wrote here, most deadly, right? Presents with fever, dyspnea, hypoxia, hypotension, or symptoms of pneumonia, classically caused by hemorrhagic mediastinitis. Right? So you're going to see widening of the mediastinum. Patients typically do not have pulmonary infiltrates, right? Because it really just causes hemorrhage. That's it. GI occurs after the ingestion of poorly cooked contaminated meat, can present with dysphagia, nausea, vomiting, bloody diarrhea, and abdominal pain. This is probably the least commonly tested. GI anthrax is not that commonly tested because it's just not what really happens. People that work in these fields, right, in any of these occupational things, are pretty well warned and trained, so they usually have masks on and stuff like that, and they take care of themselves. But breathing something in can occur, but they don't eat in this area. They definitely don't eat around here, so they won't get the GI problem. Now, diagnosis criteria for diagnosis includes culture isolation or 2 non-culture supportive tests like PCR, immunochemical staining, or ELISA. Chest X-ray is the most sensitive, especially for the inhalational disease, where you're going to see the widened mediastinum and pleural effusions, right? But you're not going to see pulmonary infiltrates. Do not have pulmonary infiltrates, right? Treatment: ciprofloxacin or doxycycline plus 1 to 2 additional antibiotics for at least 14 days for the inhalational disease or the cutaneous disease of the face, head, or neck, sensitive areas. For other cutaneous disease, treat for 7 to 10 days. Post-exposure prophylaxis to prevent inhalational anthrax should be continued for 60 days. Right? So very important to understand this breakdown here, because although when you read it and you're like, okay, I get it. Then you do questions and you're going to get all these days and numbers messed up. So you got to be very careful. So basically, you give Cipro for at least 14 days for the inhalational disease, right? And then if it's just cutaneous disease that's in the face, head, or neck, you also give it for 14 days. If you just have a cutaneous disease anywhere besides the face, head, or neck, you just give it for 7 to 10 days. And you also give Cipro for 60 days to these same people because you want to make sure they didn't inhale it too. So post-exposure prophylaxis is a key thing. So you might get a whole breakdown of an anthrax questionnaire where a guy got this black eschar, you prescribed him cutaneous, for his cutaneous disease, you prescribed him the Cipro for 10 days. What else should you do? Give him more Cipro for the other 60 days also, right? So 50 more days of Cipro to make sure he didn't get inhalational anthrax. Okay, so it's a very tiny thing, but very important, because if you forget that, then of course you would treat the cutaneous disease, but then a couple days later or weeks later, you might end up seeing mediastinitis and whatnot because of the inhalational anthrax that didn't act up immediately. It takes some time to act up, right? Osteomyelitis. So usually most questions about osteomyelitis are going to involve people who have sickle cell. That's something that we saw when we did our hematologic infections, as well as when we did hem-onc. Bone infection caused by direct spread from a soft tissue infection is most common in adults, whereas infection caused by hematogenous seeding is more common in kids, like metastasis of long bones, and IV drug users, where it will go to the vertebral bodies. Common pathogens are online. So now, they just broke down 3 different portions you would see things in that would apparently give away the question, right? So if it is in the metaphysis of the long bones, it's going to be osteomyelitis in kids. If it gets to the vertebral bodies, it's going to be osteomyelitis in IV drug users. Right, so very important connection to keep in mind here. Presents with localized bone pain and tenderness, along with warmth, swelling, erythema, and limited motion of the adjacent joint. Systemic symptoms and purulent drainage may be present. All right, so now they have this association table here, which pretty much does the job. This is exactly how it actually gets tested. So you get a question, the patient has one of these things, which can also include the no risk factors at all, so none of these things, but then it's just SRES. So depending on what they do have, you can easily pick the correct answer choice. Right? So sickle cell is always salmonella osteomyelitis. Right? IV drug, of course, SRES. No risk factors, SRES. Chronic, SRES. Right? Very easy. If it's a foot puncture wound or a diabetic person, it's Pseudomonas. And hip replacement is like a fake thing, like a fake valve, so F's epidermidis. Right? Very easy table, to be honest. It just takes a little bit of time and experiences with these questions in practice, and you get it down pretty damn well. This question is pretty relevant. So it says an 11-year-old African-American boy with a history of multiple hospitalizations for pain crises, all related to sickle cell, presents with fever and severe pain in his right hand. Exam shows an area of redness, tenderness, and swelling near the right second metacarpal. Labs show leukocytosis and elevated ESR because he has infection and he has inflammation. MRI shows an area of increased intensity in the painful area. What pathogen is most likely the cause of his condition? Well, it's obviously salmonella. Right? SRES is the most common cause in patients without sickle cell, and is the second most common organism that causes osteomyelitis in patients with sickle cell. So if you do have a patient with sickle cell, and they can confirm it's not salmonella, then it's Staph aureus, and that's really all there is to that. Not that bad. There's a couple more practice questions at the bottom we'll look at. Labs and imaging, not the biggest deal. It's going to be pretty obvious as osteomyelitis because it's just bone pain without an actual real trauma to the area, right? So nothing happened, but you have bone pain there now. That's osteomyelitis. So x-rays are often negative initially, but may show periosteal elevation within 2 weeks. Bone scans, which are not really done that often, are sensitive for osteomyelitis but lack specificity. MRI is the tested choice. That's what you're going to pick as your answer choice. Right? Will show increased signal in the bone marrow and associated soft tissue infection. Right? So like they're showing you here. Right? So in this MRI that they're doing here, you're seeing destruction of a lower thoracic intervertebral disc with abnormal enhancement throughout the adjacent vertebral bodies. Right? With the arrows. And a posterior rim enhancing epidural abscess, which is this right here. Right? In the spinal canal. So of course, if it's affecting this area in the spinal canal, then that must be someone with vertebral body involvement due to IV drug use. And you pick that as an answer choice. That's it. Right. Most accurate test is a bone aspiration with gram stain and culture. Clinical diagnosis made by probing through the soft tissue to bone is usually sufficient, and aspiration carries a risk for infection though. Right. So don't do too much, just a little bit inwards, and then you get the probe there and you pick it up, you get the aspiration, and you're done. Treatment, most accurate treatment is surgical debridement of the necrotic infected bone, followed by IV antibiotics. Remember, it's hematogenous, so you need to get it into the blood and get it to the bone. Empiric antibiotic selection is based on the suspected organism and gram stain based off of their life and style and their age. Consider clindamycin plus ciprofloxacin, ampicillin, sulbactam, oxacillin, nafcillin. Nafcillin is a very good one, especially for MRSA. Right? Vancomycin, again for MRSA, but you can also have vancomycin resistant. Or ceftriaxone, cipro for gram-negative bacteria. Right? Chronic osteomyelitis, sepsis, and a bunch of other things can occur, including this thing. Long-standing chronic osteomyelitis with a draining sinus tract may eventually lead to squamous cell carcinoma, which is a marginal ulcer. Right, so if you get a question where you have the draining sinus tract in someone who keeps getting osteomyelitis, and then they ask you what are they at risk of, squamous cell carcinoma. Right? This question here is relevant to that, so most people messed it up though. 50% chose the wrong answer choice. 56-year-old man comes to the office due to a right foot ulcer that is not healing. He first noticed a small wound on the right sole 2 weeks ago, but does not remember any trauma. He applied over-the-counter antibiotic cream, but the wound gradually enlarged and began draining foul-smelling material. So it is draining, and this was the key thing here, that he has pain, right? He has foot ulcer and whatnot, but there was no trauma, right? Where did they say that? Does not remember any trauma, right? No trauma. So that's a pretty key thing. That's osteomyelitis, basically. He has had no fever or significant pain. Has a history of hypertension and DM2. Right foot exam shows a 2 by 3 centimeter plantar ulcer under the first metatarsal head. There is purulent exudate, and the bone can be palpated with a sterile metal probe. Distal pulses are present, but lower extremity sensation to light touch and pain is not so good. Hemoglobin A1C is 8.9%, so this patient is diabetic. What is the best next step in management? And the correct answer was metatarsal bone biopsy. 30% of people picked it. But 50% chose swab and culture from the wound base, which obviously feels like a very easy thing to do and a pretty viable answer choice. Not the craziest answer choice that, someone should be ashamed of picking, but metatarsal bone biopsy was the thing to do here, right? His issue is pretty deep in, not just at the opening of the ulcer, right? So wound base would be pretty external. It's outside. That's not where the core problem is. The core problem is coming from deep inside. Patients with diabetes have multiple risk factors for the development of infected foot ulcers, including peripheral neuropathy, hyperglycemia, and peripheral arterial disease. Contiguous extension of the infection from the ulcer to the underlying bone causes osteomyelitis. Because this complication may be asymptomatic, patients with diabetic foot ulcers should be assessed for extent of infection. As seen in this patient, the presence of a positive probe to bone test, where you palpate the bone with a sterile blunt wood or metal tool, a large ulcer more than 2 centimeters or an ulcer lasting more than 1 week increased the likelihood of osteomyelitis. Right? They did that. They did the right foot exam, right? And then they said there's purulent exudate, and it can be palpated with a metal probe. So that's what they're talking about there. Fever, pain, and elevated ESR and sinus tract damage may be present. The most specific diagnostic test for osteomyelitis is bone biopsy and culture. Positive superficial wound cultures do not reliably predict the culprit organism because the problem is too deep. Even among patients with diabetes and foot ulcers who do not have osteomyelitis, wound-based cultures should not be performed following debridement and curettage rather than following a simple swab from the wound base. Right, so wound-based cultures should not be performed following debridement rather than following a simple swab from the wound base. So that wound-based swabbing thing is not what you need to do. And we saw that here already. Right? MRI or bone aspiration. That's it. So aspiration, you need to go and get the biopsy. Right, very, very big thing here. So evaluation of vertebral osteomyelitis. I put this table here because it's relevant to this. If you do it, you would do it because you have a patient with fever, back pain, and focal spinal tenderness. So you get a patient with fever, back pain, and then tenderness right here when you palpate their back. You do the evaluation with blood cultures, checking for plain spinal x-rays. Plain x-rays, nothing crazy. Just do a plain x-ray, which is very cheap and easy to do and very quick. When you do the plain x-ray, initially, you might have seen in blood cultures and inflammatory testing that everything is high, but the x-ray may look normal. So now you order an MRI. So when you get this, why is this diagram such a big deal? Because you can get questions about this exact patient here, and at this point in the beginning, the next best step answer choice would be to do a plain spinal x-ray. After everything here, the next best step is to do an MRI. You don't just order an MRI right away. And when you do the MRI and you found where things are problematic and it all looks like this guy and it all looks like osteomyelitis, now you can go ahead and order the CT-guided needle aspiration biopsy to grab this shit, right, and then test it out. This question here, though, the correct answer was MRI, but watch how they do this. 60-year-old man comes to the emergency department with a 10-day history of malaise and lower back pain. He has tried high doses of acetaminophen with no relief. His past medical history is significant for BPH and recent UTI treated with ciprofloxacin. So, of course, they mentioned the BPH because, first of all, very key thing to remember, BPH does not mean that you're going to get prostate cancer. Right? The two things do not have that big of a correlation. But of course, it could lead to prostate cancer, but clinical trial wise, there's no correlation. People get prostate cancer without having had BPH, or people get sudden BPH, which just becomes prostate cancer. And of course, they mentioned this here because prostate cancer can cause back pain. Recent UTI treated with ciprofloxacin is probably less relevant. He reports resolution of the urinary symptoms, so that's good. Temperature is very high today, though, for some weird reason. Physical exam shows exquisite tenderness over the L4-5 vertebrae and local paravertebral muscle spasms. Neurologic exam shows 2+ DTRs and 5 out of 5 muscle strength. So deep tendon reflexes and muscle strength are all working fine. The straight leg raise test is negative at 0 degrees. So straight leg raise test is a key thing here to show you that this back pain is pretty problematic and that there might be an abscess. The prostate is mildly enlarged and non-tender. Labs are showing you a bunch of stuff here, but most notably, this is key. He has infection and inflammation. Plain x-rays. So you see, they ordered the plain x-ray. Remember, questions teach you. So they ordered the plain x-ray first. They did that. Plain x-rays of the lumbar spine show mild degenerative changes, which is not that big of a deal. He's 60, so you would see that. They also ordered the blood culture and ESR CRP stuff, but they haven't given us the blood culture in the question. However, they did give us the ESR, right? So now what do? Well, now, because he has inflammation, he has infection, and plain x-ray didn't show much, you order the MRI. So you see how this question down here follows this path perfectly? And you can get questions where they didn't do the plain x-ray yet, and then they ask you what else should you do, or what's the next step in management, you order the x-ray. Then, when the x-ray comes back normal with just basic, obvious changes, you can go ahead and order the MRI. But you're going to have both answer choices there, X-ray and MRI. Right? His presentation suggests vertebral osteomyelitis, most likely due to hematogenous spread of his recent UTI. S. aureus accounts for about 50% of cases of pyogenic spinal osteomyelitis. Fever may or may not be present, and physical exam shows exquisite focal tenderness. Epidural abscess can cause severe back pain and sensory impairment, possibly leading to paralysis. You see, is the abscess that they were checking for with this test that you may not have seen before, the straight leg raise test. Right? You can't do the straight leg raise test if you have an abscess in your spine. So this question teaching pretty nice stuff. Not only did the question teach this abscess and straight leg raise testing, this question is also teaching you that the UTI was very significant because although the Cipro fixed it in his urinary problems, the UTI culprit actually spread hematogenically to his spine. So now they go on and say leukocyte count may be normal, but ESR and CRP are usually very high. MRI would detect the osteomyelitis and epidural abscess and cord compression. Radionuclide bone scanning with gallium is an alternative for patients who cannot undergo MRI. CT guided aspiration, so the bone biopsy basically, confirms diagnosis. Right. Here you wouldn't necessarily do the bone biopsy, that was for this guy. Here you would just get the aspiration of the actual thing once you've located it. Right. So a couple little technical things here and there. Right. Actually these technical things are the base of this test though. Right. This test is only hard because of the technicalities of ordering one or the other test. Clearly, if I have this patient and I order an MRI without ever doing the plain x-ray, things are going to be fine. In fact, I'll probably save a little bit of time and money. But that's just not the procedure. Right? The procedure is to do the x-ray first, then the MRI, and you need to just do it in that way because that's what is most effective. I'm sure there are some things that the MRI wouldn't catch, but the x-ray would help identify. Right? So that's something you have to keep in mind. Don't mess that up. Right? And with that, we're done with infectious disease. So if there's any microbiology that you don't remember, you want to make sure you go back and look at it. As far as MSK is concerned, this chapter is mainly all stuff to do on your own. There's not much for me to talk about. It's mainly a read-through on the book. But I will run through it with a couple things. There are a couple things I want to talk about in a little depth, like the bone cancers, osteoporosis versus rheumatoid arthritis versus osteoarthritis, where that's discussed. Oh, this thing. Right, osteoporosis, osteoarthritis, and rheumatoid arthritis, and the main differences between some of these arthritic lesions. I will talk about that a little bit. I'm going to talk about lupus, right? We're going to talk about, I think that's about it, yeah. and a couple things that I'm going to go back to step 1 MSK to discuss as well. So we'll do a run through of this chapter this month as well, just not in crazy depth. A lot of it is just going to be mainly self-reading, and I'll do the practice questions that I've got throughout the book here to help understand some of these topics and revise like a little bit of the anatomy. But that's generally all MSK is going to be, so that we can quickly jump into neuro, the next really big, difficult topic that does require more than just self-reading. All right. So that's it for today. Thanks a lot for joining, guys, and I'll see you guys tomorrow morning.